So my name is Zac Lowth. I'm the Head of Growth and Customer Success at Carelever, and this morning I'm joined by Dr. Matt Brandt, who's the Chief Medical Officer and Senior Medical Specialist and Consultant Physician in Occupational and Environmental Medicine. Matt, I hope I got that right. Very good. So this morning's webinar, we're going to run through an interview with Dr. Matt Brandt, and what we're going to cover off is the epidemiology of silicosis and the legislative background around RCS. We're also going to look at some of the current legislative requirements for health surveillance. We know that there's a lot of health surveillance, done in this area. It's highly topical at the moment. There's been an ongoing parliamentary inquiry in New South Wales, and extremely topical in the news around some levels of exposure, some diagnoses. So really important, I think, that we have this discussion with Dr. Brandt, and businesses can know what they should be doing and what quality and high standard looks like. We want to share, what happens if a case is identified during health surveillance, and just at a high level, what to do if there is a diagnosis. We will also then be running through a Carelever demonstration, so just showcasing how insured RCS compliance, looks in the platform, and we can also show you some spirometry comparative insights as well. Look, we are really open for this being a question and answer session as well towards the end. So if you do have questions, please pop them in the Q&A. We've got Katrina from KINNECT who will be moderating in the Q&A. Okay, so any questions, please drop them in the Q&A, and we'll have time to answer them at the end. So without further ado, I wanted to introduce Dr. Matt Brandt and really wanted to dive into it. Firstly, to look at the epidemiology of silicosis. And my first question to you, Matt, today is, how big of a problem is silicosis in Australia today?
Yeah, thanks, Zac, and good morning, everybody. It's a really important question. It's very topical. First of all, what is silicosis? It's a fibrotic scarring disease of the lungs caused by cumulative exposure to respirable crystalline silica, otherwise known as RCS, and I'll use the term RCS for brevity. Silicosis has re-emerged as a really serious health issue in Australia, particularly over the past decade or so. It was really originally thought to be a disease of the past, but it's returned with quite worrying speed, especially in certain high-risk industries. It's important because it's an incurable and potentially fatal disease, but it's also entirely preventable. In terms of the epidemiology, RCS exposure does currently pose a risk to workers across a range of industries. You'd be aware of the issues of the epidemic of silicosis arising in engineered stone fabrication workers over the past decade. So these workers were considered to be among the most at risk because they were performing dry ketting methods in poorly ventilated areas on materials containing over 90% crystalline silica. And this led to, I think, an epidemic, if you like, of silicosis cases, particularly in younger individuals, and there were a number of accelerated cases of silicosis as well. Construction, including tunnel work, has the largest population of workers at risk in Australia.
And Matt, if we dive into that, is it just construction, do you think, that need to be, concerned about silicosis, or are there other industries, as well, that need to have this in mind?
For sure. I think quarry operators and miners as well. So particularly wherever we're disturbing or crushing high silica rock. But in terms of the pure numbers of workers at risk across the construction sector, which obviously includes tunnel work, that's probably where we've got the largest at-risk population of workers. And it's where we've got dry drilling or blasting methods where we haven't got adequate dust suppression, and that's where the serious risk can arise. And I think, as you mentioned before, Zac, there's been quite a significant sort of well-publicised concern in regard to the tunnelling sector.
Sure.
But a lot of major infrastructure projects underway in several cities, and because of a lack of space above ground, we're having to create more tunnels. And unfortunately, we've got a very high silica rock based on the geology in quite confined environments. Studies have shown that road headers, so a particular component of tunnel construction, had the highest measured exposures to RCS well over the occupational exposure limit. And of concern today, I think, is the finding that there's an estimation that about 10% of tunneling workers will develop silicosis at some stage because of exposures to RCS. That's a real concern, given
And
the
Matt,
number.
could you quantify that? I mean, what number of workers are we talking about there in Australia?
It's really hard to know because we don't have any great, as yet, we don't have any great sort of incident statistics. But obviously, with the National Dust Disease Registry, we're going to be collecting more cases. So I think the actual numbers will become more apparent. But 10% of a pretty large cohort of workers is a concern. We could be looking at a few hundred cases over the next 10 years, potentially.
And you mentioned, Matt, with it being, I suppose, incurable. We might touch on that a little bit later, but you did mention that it is entirely preventable as well.
Absolutely, yeah, absolutely, and it's really around minimising exposure at source. We've actually seen quite a sharp increase in diagnosis of silicosis in the last few years. We've had comprehensive health surveillance screening programs. We've picked up quite a few cases for some of our tunnelling clients. But I just want to talk a little bit about, Zac, just what we mean by silicosis, because there are different types of silicosis.
For sure.
There's a spectrum of, I suppose, severity and progression of the pathology. We'll start with what's known as uncomplicated or simple silicosis, where you might have very small nodules within the lung itself. You might have some involvement of the lymph nodes around the lung, but they're generally very small nodules, small areas of scarring and inflammatory cells, which typically develop quite slowly after long-term low-level exposure. And we see a lot of those cases when we pick new cases up in health surveillance.
Yeah, okay.
Then there's complicated silicosis. So that's where the actual pathology in the lung itself progresses to the development of large masses of scarring, or you might have also heard of the term progressive massive fibrosis.
Yeah.
Once the disease process progresses to this particular stage, folks are often quite symptomatic. They've got reduced lung function, and generally speaking, once the pathology reaches its stage, it's likely to progress further, but it could be slowly or rapidly progressive. So we don't want to have people coming to that stage. You might have heard of the term accelerated silicosis. So that's where there's been progression in only a few years, so less than 10 years, in workers exposed to really high levels of RCS. And this was identified in the engineered stone workers a few years ago.
Yeah, okay.
Yeah, and there's another really rare condition called acute silicosis, which is a severe, generally fatal form of silicosis that can develop within a few months if there's been extremely intense short-term exposure. We don't tend to see those cases in Australia.
And Matt, you just mentioned reduced lung function, and I just wanted to talk to you about that, because obviously spirometries are a really important part of health surveillance. But do you think that spirometry, I suppose, is picking up the early stages or later stages silicosis? And what type of other investigations can we do, I suppose, like radiology, to pick up silicosis in more early stages?
Yeah, I can talk that now. Or we've got a later there's a later stage of the presentation on health surveillance. I'm happy to discuss it then, where I will talk about. But I think to answer your question, it's a really important question. Spirometry is not a sensitive measure of early silicosis, and in fact, neither is an ILO chest X-ray, because studies have shown, for example, that you could have an ILO chest X-ray showing 0/0 perfusion, which is effectively what appears to be a clear lung. And there've been workers who've been, the same cohort of workers have had a low-dose HRCT scan and have identified silicosis within the lung itself. So spirometry isn't a particularly sensitive, and in fact, you probably need to see some progression of disease before you get a decline in spirometry over time. Yeah, so it's really important though, because it's one of the tools we have in, and I will come back to this a bit later, but it's one of the tools we have in monitoring long-term lung function, particularly in high-risk workers.
For sure. And Matt, my last question on this slide, just before we move on, have you seen any shifts in diagnosis trends due to improved screening or reporting, and any difference between screening and reporting there?
Yeah, absolutely. I think the first comment is that early diagnosis is essential. And one of the positive trends that we're now seeing is earlier diagnosis. It's not because the problem's going away, but it's because the screening methods have improved. And some jurisdictions, particularly Western Australia, now require a low-dose HRCT chest rather than an ILO chest X-ray. And so that's actually meaning is that there are early changes of disease being picked up in the lung earlier and more accurately. I think the other thing is that there's now greater awareness amongst clinicians and also amongst the regulators, which is leading to better reporting as well. And now with the National Dust Diseases Registry, there's mandatory reporting for silicosis by the diagnostic physician, most commonly a respiratory physician. So we're going to have a better understanding of the numbers of cases as well. So I guess in summary, it is a major and growing problem, but I think we're now in a better position than ever to detect and manage if we act early, if we act decisively. Just want to make another point. There is benefit in early diagnosis. It isn't simply leading to a longer period of time that the person is aware of the disease. There are some interventions such as whole lung lavage, which is a procedure carried out by obviously an expert respiratory physician, where saline solution is used to effectively rinse out or flush out the lungs. Sounds awful, but the aim is to reduce the crystal burden and the inflammation in the lungs. So there's some hope that perhaps this could certainly retard any further progression of disease in people for which this intervention is beneficial for. And I know that a number of patients have had this procedure already. So that's a promising intervention. I don't think it's a cure as such, but it certainly could allow someone to remain at a sort of a non-progressive stage for much longer. So there's many good reasons to want to try and diagnose early.
Yeah, great. That's a really important point, Matt. I know that in the New South Wales parliamentary inquiry, there was a few earlier this week. There were a few points made around, workers, not engaging in, not necessarily wanting to know about a diagnosis. Yes, I think that's a really good point that you make.
Yeah, I mean, it's a life-changing diagnosis. I think part of the management is obviously the psychological support, particularly in someone who's still an active member of the workforce. So it's a profound, life-changing diagnosis. And I must remember, it's not just about the physical changes and the diagnostic and interventional procedures. It's about supporting the whole person as well. So you also made a really good point there as well.
Yeah, for sure. So, Matt, if we then dive into the legislative background around RCS, and we do use the term RCS for brevity, as you indicated earlier, how has the regulation, of respirable crystalline silica exposure evolved in Australia?
Yeah, broadly speaking, there has been, I think, a quite significant change to the regulatory framework over the past few years. We've had mandatory exposure standards for a long, long time under the work health and safety regs, but those standards weren't considered to be stringent enough. Until fairly recently, the workplace exposure limit was set at 0.1 milligram per cubic metre. So that's the personal air monitoring for respirable crystalline silica. But in 2020, Safe Work Australia recommending halving that limit to 0.05 as an 8-hour time-weighted average. So that brings Australia in line with best practice. I think most jurisdictions have now adopted this lower standard. But I think what really accelerated the sort of change in Australia was what we saw in the engineered stone industry. It was an absolute crisis. Yeah, okay. It was horrendous. It really was. And obviously, as I said before, the National Dust Disease Task Force has been created. And I think all these changes are underpinned by a realization that the existing controls weren't helping.
Yeah.
Particularly in the smaller businesses or trades which didn't have the strong safety systems available.
And do you think that pressure to change, Matt, do you think it came from, was it public pressure or was it pressure from, so I suppose, the occupational health, medical world? Like, where do you think that pressure came from to change the legislation here in Australia?
I think the medical profession played an important role. I think there was strong advocacy from unions. I think the lung health specialists, the Thoracic Society of Australia and New Zealand. So I think there was a combined sort of effort to sort of improve the regulation around dust diseases generally. Obviously, we had the Monash inquiry regarding the Queensland pneumoconiosis issues and respiratory health surveillance. So I think there's been a combination of sort of community and political advocacy for change.
Yeah, okay. And Matt, in those high-risk industries, I mean, what would your tips be to ensure that they're complying with the legislation they need to?
Goodness me, and I'm not a lawyer here, everybody, so just I've provided things from a sort of occupational medicine perspective. Obviously, we've got the stick of the regulation, but it's not just about meeting these exposure limits. It's about proactively managing risk. And I think for high-risk industries, particularly construction, tunnelling and quarrying, it's about conducting regular air monitoring. It's about prioritising engineering controls at source. water suppression, local exhaust ventilation, and so on, ensuring that your safe work method statements are reviewed and updated regularly and educated to the workforce, and most importantly, engaging in periodic respiratory health surveillance for those workers who are at risk. So I think there's a lot of things that that need to be done. And I guess, for those businesses that don't comply with these requirements, they do risk, I would presume, quite significant enforcement penalties from the regulators, and I guess potentially liability if a worker is later diagnosed with silicosis and it turns out that health surveillance was missed for those individuals.
For sure. And Matt, do you think we will eventually move to a more nationally consistent approach, or do you see state level differences kind of posing challenges? I'd be interested in your thoughts there.
Yeah, look, and again, I'm not involved in the political process, but I think I would hope that we eventually do move to a national harmonisation of health surveillance requirements. It do still vary somewhat by state. So I think, yes, that we do need that. I think that there will be strengthening enforcement for non-compliance, especially among subcontractors.
Yeah.
I think obviously we've seen the legislation regarding the ban on engineered stone. I think we may find enhanced licensing and certification schemes and regulation for other industries as well. So I guess watch that space. I think the regulatory bar will get higher.
Yeah.
In short, but I said I'm not particularly closely aligned with what's happening in the regulatory perspective at this stage.
And Matt, where you say that the regulatory bar may get higher, what do you see? Sorry, is that next frontier? What may be the next thing that's changed?
Yeah, no, I'm not sure, but I think, as I said, I think there's going to be strengthening enforcement for non-compliance, and I think that we'll have a national scheme eventually.
Yeah, okay.
We have so many different things happening in different states and jurisdictions for different sectors. It's still somewhat varies. So I think we're going to get more consistency eventually.
Yeah, wonderful. And that probably flows on really nicely into our next slide, which is a discussion around health surveillance. And Matt, I know that you're a specialist in this area. So if you could, what are the current legal requirements for RCS health surveillance?
Yeah. So under work health and safety regulations, employers are legally required to provide health surveillance to any worker who has a significant risk of exposure or risk of harm from exposure to a hazardous substance. And obviously RCS is one of them. There's a list of scheduled substances, but there are also general requirements around health surveillance for other substances that aren't listed in that scheduled list. So in terms of RCS, the starting point is the risk assessment. So obviously working with the PCBU, the assessing medical practitioner is guided to assess exposure risk. And the recommended method is to use what we call an exposure risk matrix, which is a structured tool that guides us to classify exposure dose. So what we're talking about is a combination of the duration of exposure, typically in years, and the intensity of exposure, which is the average sort of concentration in the breathing zone, or the personal monetary exposure, which will depend on the type of task performed. Tasks that increase the risk are those where someone is actually performing or working in the vicinity of dry tasks, so where there's no water controls. And we also consider how long someone has been doing this and how often they've been doing it during their workday. So that's sort of the general approach to identifying risk. For example, a tunneler who has worked for 5 years would typically be classified as a higher risk worker. There might be others in a sector who are working near activities but not right in the vicinity, who might only occasionally have exposure, so they might fall into a lower risk category, not a zero risk category, but a low risk category, depending on the air monitoring results, depending on the control measures in place. So that's sort of the risk assessment.
For sure.
There's also other flags to risk assessment that, so if a task would not be considered under control if there are short-term exposures that are more than 3 times the time-weighted average for more than 30 minutes per shift, or if a single intense exposure exceeds 5 times the time-weighted average, even if the 8-hour average looks acceptable. So those sorts of exposure risks significantly increase the risk of future risk of silicosis, particularly if it's happening on a frequent basis. So that's the risk. If someone is identified as at risk of RCS exposure, there are legislative health surveillance requirements. Did you want me to go through them now, Zac?
Yeah, absolutely. That would be great because we'd love to know what best practice health surveillance then looks
Yeah.
like.
Well, look, yeah, whilst they vary from scheme to scheme, there is a commonality. So obviously there's a detailed occupational exposure history, a respiratory symptom history, a respiratory questionnaire, which is a standardized questionnaire that's generally the same questionnaire asked across jurisdictions, a clinical examination for air entry and lung sounds, high quality spirometry that has to meet the TSA/NZ quality criteria. That's going to be done at least annually. And look, I realise it varies from jurisdiction to jurisdiction. Here in the mineral mines and quarry sector in Queensland, it's obviously up to the discretion of the supervising doctor. But for the other jurisdictions, it's done at least annually or even every 6 months for those really high risk exposures. Because again, we're wanting to detect early any change in airflow. Now, all health surveillance does require radiology.
Yep.
And the National Safe Work Australia requirements stipulate a minimum of a B-read ILO chest X-ray at least once every 5 years. And now there's a departure from this. So in Western Australia, for example, low-dose HRCT scans are mandated. So this is a very thin slice of scan of the lung. And as I mentioned before, have a higher sensitivity to detect early changes than a chest X-ray. With some of our other clients that are not under the Western Australian regime are also recommending periodic or requesting periodic low-dose HRCT scans. My sense is that it shouldn't be for everyone. We really need to, I think, assign those sort of recommendations to the very high risk cumulative exposure dose workers. Bear in mind now, though, that the low-dose HRCT scans have markedly reduced exposure compared to CT scans in the past. So much
Yeah,
lower
okay.
level of radiation.
Do you see that as a common concern with HRCT scans, Matt, like that's brought up by workers or businesses?
It's mainly businesses. There have been some concerns raised, and we have reassured our clients that if it is required, it's a very, very low dose.
Yep.
The benefit of actually having the scan in a high-risk worker far exceeds any very low risk from radiation exposure.
Yep.
There are other reasons why we might recommend a low-dose CT scan. If someone's got concerning respiratory symptoms, even if the spirometry is okay, we might want to investigate further to see if there's some structural changes happening in the lung, or if someone's had a significant decline in spirometry over time, 15% loss or more of some of the key airflow measurements, over that period, then I would certainly be wanting to have that person have a CT scan, a HRCT. And the other thing about health surveillance is it is required to occur, based on or early on in the commencement of the work, periodically, and then at exit as well. One of the things that concerns me is that my sense is that even after people leave the sector and they've had perhaps their exit medical, my sense is they probably do need some ongoing surveillance thereafter indefinitely, but I don't know how that can be done because obviously it's not required.
Yeah, for sure. And I mean, there's been a lot of conversations around exit medicals as of late as well. Where do you sit there, Matt? I suppose, when you might have a business ask you for your position on exit medicals and whether they should be done for a worker who has had ongoing RCS exposure.
Yeah, they are required to be done. So they're actually mandatory. So when they leave the sector or leave the role, so they are absolutely required.
Yeah, great.
But the concern, of course, is what changes might then occur 5-10 years after they've finished in the sector. Because one of the other things about silicosis is that, generally speaking, it usually only develops sort of 10, 15, 20, maybe 30 years after exposure started. So someone might hop around between different employees in the sector, and then they might leave the sector and go into a different employment sector.
And then they may have that diagnosis of silicosis later in their life.
Exactly. Could happen. Yeah. So I don't know what the answer is, but I think there needs to be more focus on health surveillance of workers who've left the work, but we still want to keep an eye on them.
Yeah, for sure. That's a good point. And Matt, you did touch on this just earlier, but what does occur if a business doesn't comply with their legislative obligations for health surveillance?
Well, they obviously risk significant consequences from the work health and safety regulator, enforcements, presumably penalties and fines. The other concern, of course, is potential liability if a worker is diagnosed with silicosis, and it turns out that health surveillance was missed. So that's a pretty serious consequence. But it's not just about checking the box and meeting legislative requirements. It's about early detection, wanting to help your workers stay safe, healthy, and well, and make sure that we don't have workers slipping through the cracks as well.
Yeah, certainly. And on really well into our next slide, which is a bit of a dive into what happens if a worker is diagnosed with early stage silicosis. And I know, Matt, that you can't share specific examples, but at a general level, I'd love for you to be able to share some of your experience in this space.
Yeah. Well, let's step back a little bit and think about how the diagnosis might be made. So it's, it might already have been made prior to the worker coming into the sector. So they may have actually come in and disclosed that they already have silicosis, and they're just moving into a different employer or perhaps a different work environment within the sector. So they may come in with a diagnosis already, and that's been the case in for a few individuals that we've seen. More often than not, though, it's going to be picked up because of issues that are identified during a health surveillance, sometimes at baseline, so to speak, but more often periodically. And it will be based on concerns, perhaps an abnormal CT scan, or there's been perhaps some symptoms, some persistent respiratory symptoms. So they get referred to a respiratory physician who will undertake the diagnostic workup. In order to do that, they need the worker's occupational exposure history, and that's critically important. We actually need the smoker history as well, because we know that smokers are more likely to develop silicosis than non-smokers with the same sort of exposure history. The respiratory physician will obviously assess and examine the individual. They'll do some quite, I think, advanced lung function testing. We call that complex lung function testing or laboratory lung function testing. So it's not just spirometry. They'll measure the lung volumes. They'll look at how well gas transfers across the lung surfaces, which is a huge potential problem with silicosis, because it reduces the surface area of our lungs that's available for oxygen to move across. So they'll do the testing, the HRCT, the assessment, including exposure history, and then they'll confirm a diagnosis. Now, once that's confirmed, the respiratory physician will obviously communicate directly with the worker. They'll provide a written report back to the referring provider, so whether it's the treating GP or whether it's the supervising doctor for health surveillance, so either myself or one of my colleagues. There's then mandatory reporting by the diagnosing respiratory physician to the National Occupational Respiratory Disease Registry. So this registry is relatively recent, but it is legally required to report the diagnosis. Some jurisdictions will also require reporting to the WorkSafe regulator. Now, when we produce a health monitoring report for the PCBU, that will also indicate the diagnosis of silicosis if it's present, and any adverse effect of exposure, and that includes silicosis in this case. So that's, I suppose, the initial process of reaching a diagnosis and who's involved. The employer obviously has a clear duty of care, but the appropriate action depends on getting good advice from an occupational physician and the respiratory physician. And I think and this is a really tricky area. I've been grappling with this, as have my colleagues. And I think where to go really depends on how advanced the disease is and whether it's progressing. Zac, it's impossible to describe what increment of additional cumulative exposure may result in a currently stable disease, subclinical, so not causing any symptoms, developing into a more rapidly progressive disease. They could remain stable for years and years. We know that,
and that's not uniform, Matt, between person to person. Does it change?
All silicosis will progress to a degree over time, but it can be very, very slow, and it can be quite stable for a long time. So people can be actually pretty well. And my sense is that unless there's a specific clinical reason, so unless someone's got significant lung airflow impairment and poor exercise tolerance and so on, there's usually no urgent need for a worker with early stage silicosis to leave the workplace straight away. Now, this is a significant potential impact on their well-being, their ability to pay the bills, their sense of having a job. And I understand that some workers may, on the other hand, be very fearful and not want to return to that environment. So with that initial situation, whilst it's best prudent to avoid any further exposure to dust, if the individual's in an environment with levels are well below the workplace exposure standard, their condition is unlikely to be significantly worsened by current situation, provided there's no risk of these short-term high-intensity exposures that I talked about a bit earlier. So the disease is already established, and it's there because of past exposures. So if the worker has simple early-stage silicosis and we've got evidence from the respiratory physician that it's not progressing, if the lung function is preserved, if the scan shows limited findings, it may be reasonable, with agreement of all parties, including the respiratory physician and the worker. It's a patient-centered decision-making process for the worker to continue working in a role with potential exposure. But there's a number of provisos, Zac. So there need to be very diligent, high-standard dust control measures in place. And the individual needs to be enrolled in what we call an enhanced health surveillance program. So that's basically a lot more health surveillance than they had before.
And that's going to be. And what does that look like, Matt?
So generally, it's up to the respiratory physician and the worker to determine what it looks like. But typically, it's going to be minimum of a yearly review by the respiratory physician, maybe more frequent. They're going to have frequent lung function testing, including gas transfer that I talked about before, and regular HRCT scans, because what we're looking for is evidence of progression. And the respiratory physician needs to be familiar with the work environment and the exposures and the control measures in place. So that's the best case scenario. But if we have a worker, we've seen a few cases of workers where they develop progressive silicosis or complicated silicosis, or you know, if we're following up with enhanced surveillance and their lung function is declining, the recommendation is very clear. They cannot continue in any role with silica exposure, no matter how well controlled it might appear. Because in those cases where it's progressing or it's complicated already, or their lung function is declining, even small amounts, very minimal amounts of exposure may actually accelerate the progression of the disease. So I've got sort of two different situations or scenarios, but it's also a grey area as well.
Yeah, okay. And Matt, are they two very different long-term pathways and long-term outcomes for those workers?
Well, obviously we don't know. I mean, it's not a, it's, you know, as I said, it's an incurable disease, so it's very hard to know. But in terms of the socioeconomic outcomes, clearly for the worker that can stay in the industry, they're able to continue working and be remunerated and have a degree of, I think, psychological safety by working. For those workers who need to change sector or can't continue working, there's some pretty significant consequences to being out of work or having to transition to a new career. And bear in mind, some workers, this is all they've ever done. This is their niche expertise.
Yeah, for sure. And I mean, how much responsibility does the employer bear, Matt, there in helping them, I suppose, retrain and find work which is going to be suitable for them moving forward?
Yeah, it's a good question. Maybe that's a question for our employer participants today. What they would do as well. Look, I think ideally we want to be looking at some form of deployment or transition support for the worker, making use of their transferable skills. Supporting them with psychological, access to psychological support, and really close collaboration with the worker and the treating team as well. I think those workers who are able to continue working and have currently stable, simple silicosis, they're going to need lifetime monitoring. So regardless of where they're working, it's going to be lifetime monitoring. They may be able to continue in a modified role with stricter surveillance, with air monitoring and risk controls. But I think at the end of the day, they all deserve support and thoughtful, emotionally intelligent leadership.
Yeah, for sure. And I mean, for the employers, I know that we have a number on the call this morning as well. If there are, diagnoses or potentially like a small group of diagnoses, is that a flag to them, I suppose, to look at what's going on with controls, with the work and with the exposure levels?
Yeah, I think, it's a sentinel event, if you like, that might indicate, that there are some specific issues going on, potentially in a SEG, for example. But we recognise that across, particularly across the tunnelling sector, but broadly across the construction sector, they are at risk. So it's certainly it's a lag indicator of health and safety risk management. It's not a leading indicator, but it could certainly help to sharpen focus on the effectiveness of controls as well.
Yeah, for sure. Thank you, Matt. Then if we think about, I suppose at a population level, how can we ensure compliance, with regards to health surveillance? We often look at systems, that can have in place and we use Carelever, so we're going to have a bit of a chat about that one. But I'd just love your thoughts on the importance for, automatic reminders and reporting and data centralization to make sure that you are compliant, with your requirements for your jurisdiction.
Yeah, 100%. I think, record keeping is crucial. We're required to keep records for 30 years. We've got the capacity to do that. I think we also can help. I'm presuming you're going to be talking a little about sort of the periodic spirometry. We can help
Yes.
by logging, and so we can provide the solution that our clients need to be able to help support their health surveillance needs as well. We've also got highly skilled doctors that work with Carelever as well. Yeah, I think it's massively important. Record keeping. I mean, it's legally required, but I think it's actually important for auditing as well.
Yeah, and I mean that auditing point's really important. We're often working with regulators and things like that to be able to dive into Carelever and look at audits and look at compliance effectively in real time, which we'll show everyone in a second. But a question that I often have is that big versus small business. We'll have bigger businesses who'll look at a system to bring this to life, but sometimes the smaller businesses aren't exactly sure whether that is something they should be doing. I mean, what advice would you have there, Matt?
Yeah, absolutely. Continue doing it. Obviously, it's a part of your safety management system. I think it's a crucial part, particularly in the environment where you have a high risk exposure sector. We can certainly support clients with that, but it's got to be done.
Yeah, certainly. And just that last point, in terms of early diagnosis and reduced risk, I think you've spoken to this, really well. But what do you think is the best way, I suppose, to come to that early diagnosis? Is it radiology or is it spirometry, or does it really depend on the individual?
It'll depend on the individual case, but it's about, I think, from a health surveillance perspective, it's about having sufficient information at the outset in terms of the exposure risk, and obviously we partner closely with our clients to review and discuss the risk assessment results for the different segs. We can identify workers who are potentially at high risk, and as I said, there's a range of exposure risks for tunnelling workers. Some have quite a low risk and they're very well under the exposure limits, and some have a markedly increased risk, as I said before. So I think it's first of all identifying that there is a risk, and then from a health surveillance perspective, it's an imperfect science, but the exposure dose risk is a really good way of, I think, triaging those where, for example, where a low dose HRCT isn't mandated, triaging those who might actually benefit from that. Obviously, with the legislative requirement in WA and the DMERS sector for low dose HRCT. That has certainly, I believe, led to increased opportunities for earlier diagnosis.
Yeah, wonderful. And I think that segues well into the Carelever demonstration. So I'm just going to really short, couple of tab demonstration of how this looks in Carelever. And I think a really important point, to point out is some of the settings set up that we do relative to the different regulations. It can be quite complex, so we make sure that is covered off, all through Carelever, whether it's national standard, Queensland standard, or WA standard for RCS monitoring, and then the different radiology that goes along with that. So just sharing my screen so that everyone on the call can see this. So logged into our demo database here, and effectively this is what Carelever Monitor looks like. At a high level, it's going to monitor your workforce, relative to the health surveillance that they require. You can see that there are different tiles across the top here. What these tiles are doing are tracking workers, for the different health surveillance requirements. In this instance, it would be RCS monitoring. We can see that we've got Cody Construction down here as an example, who's enrolled in the RCS Silica Monitoring National, and we can see when that was commenced and the testing frequencies along that. All of these testing frequencies are built into the back end of Carelever, so irrespective of where you are, Queensland, WA or national standard, it will absolutely make sure that you meet the standard and that you could be audited and you have compliance oversight. Things like recalls and automated notifications as well, we can set up relative to the employees being due. 7 days is probably a touch short for what we're talking about, but in 30 days, if you've got some longer requirements, we can also identify employees with health risk and look at what's being done. But if I dive into Cody Construction as an example, this is a worker who we've set up to be able to do RCS monitoring under the national standard. So we can see that there's actually two programs here. There's the RCS monitoring under the national standard, and then radiology monitoring. Now, radiology monitoring is something that we've been working with our customers on setting up, because there are different, I would say, business-specific requirements for ILO X-ray frequencies and HRCT frequencies. Some businesses want, say, that HRCT every year, or they might have that alternating with an ILO X-ray. It really depends on the business's preference and then the regulation that they operate within. But we effectively set up all of those next test requirements so that when you have a medical done, it will pre-select what the next next items need to be to make sure that you're compliant. I'll show you what that looks like for RCS silica monitoring results. So if I dive into this result as an example, we can see that Cody's medical hadn't come back as fit with restrictions. And if we view that, we can see that the fit with restrictions outcome was here. We've got the actual medical, paperwork here, or effectively it's a digital form rendered as a PDF. The outcome being fit with restrictions, okay, and it's automatically telling us because of that we need to do some annual spirometry, and then there's that 5-yearly periodic medical that's done. But based on this business's setup as well, we've also got annual HRCT enrolled as well, and we can see the results here for the radiology monitoring as well. So at I would say a high level, that's the way that the health monitoring will work, and effectively, run in the background. All of the next test details are preloaded, like I said, into settings. When we have things like the legislation change, we go in and update, what all this will be, and you can see that there's a KINNECT standard, built around the different regulations and legislation, so you can lean on the system to ensure your compliance. Matt mentioned our ability to look at spirometry changes over time, and this is another worker, Carl comparative. This is a really nice example of somebody who's had quite a lot of both audiometry but then spirometry over time, and what it's doing is tracking this worker's spirometry and telling us what the changes have been. So we can see that there was baseline spirometry, periodic spirometry, and we can see in this last one there's a severe decline, and that's an indication for the doctors to look a little bit further and then dive into perhaps some imaging where needed. And if we're wanting to jump in and actually look at this spirometry, we can do that too. But it's a really nice indication for the doctors to perhaps refer some or request some extra radiology. So that's at a high level the Carelever overview we wanted to provide this morning, not too in depth, because I wanted to make sure that there was time for Q&A. So I'm going to just stop sharing my screen now and pass it back over to the group, and I can see that there are a couple of questions already. They may be for Matt rather than me, but I'm just going to open them up and see. So we've got a question here, and Matt, this one may be for you, and it's from Dustin. Thank you, Dustin. In regards to workers remaining at work with a simple silicosis diagnosis, is there anything to learn from past occupational diseases like asbestosis, or have recent improvements in early detection like HRCT created a new challenge for us to overcome?
Yeah, really great question, Dustin. Obviously very different diseases. Interesting, asbestosis is generally, the vast majority of cases have been picked up in retired workers. Obviously, most of the cases now that we're seeing have been in people who had significant exposure to asbestos through building or construction work or insulation work. And we're talking like 40, 50, 60 years ago. There have occasionally been cases of younger workers who have had some more recent exposure, but very different latency period. By that, I mean the time from when exposure started to when the disease became apparent or was diagnosed. So I don't think there's a great deal we can learn. I think the main learning for me around the silicosis epidemic is that we can never assume that a hazard has disappeared or that it's sufficiently controlled. I think for me that's a key learning. In terms of keeping them at work, I think. As I said, it's prudent risk management in that regard on a case-by-case basis. A little difficult to compare with individuals with asbestosis because most of them have retired. HRCT obviously has allowed us to diagnose early. I don't think it's created new challenges from a medical perspective because we are obviously picking up conditions much earlier. We're in a much stronger case to intervene, optimize their well-being, encourage them to stop smoking, get some pulmonary rehabilitation if we need it, potentially have some interventions like lavage, as I said before, and then we're in a position to also manage risk in the workplace. So I don't see any new challenges for us. Dustin, I'm sorry if I haven't answered your question.
Thank you, Matt. And I'll invite any other questions to come through the Q&A at the moment. I've got a question for you, Matt. It's a question that we're often asked, when we're talking to prospective clients and even existing clients who aren't exactly sure whether they should be, performing, RCS health surveillance. They're not exactly sure where they sit with regards to their exposures, and they may be in construction, but not necessarily in tunnelling, or they may be doing some quarry type work, but it's not underground. It might be in an open area. What would your advice be to them if they're not exactly sure what they should be doing?
Yeah, undertake a formal risk assessment. Use a qualified occupational, accredited occupational hygienist as well to help determine the risk. Combination of sort of area and personal air monitoring. There are some, I think in the Queensland construction sector, there are some very specific legislative requirements around silica health surveillance. And I can't remember the exact details, but if they're working with products where there's above a minimum percentage of quartz and they're using some dry methods for cleaning and so on, or other activities, then they also require health surveillance and air monitoring as well. I think the key is to do a systematic risk assessment across the business and across the different segs. We can certainly help with that and help determine priorities for health surveillance.
Perfect. Thank you, Matt. Just waiting to see if we get any more questions come through from the presentation today. I'm just going to pop up a final slide here as well. So we do really encourage everybody to stay in touch. If you want to learn more, you're welcome to reach out to me directly regarding Carelever. But absolutely, we can put you in contact with KINNECT and Matt and the team there, just to understand, I suppose, what best practice looks like and whether KINNECT may be able to assist. Matt, do you have any closing remarks? I suppose just on RCS and silica in general. If you could just provide one final takeaway for us to finish off with.
Final takeaway, goodness me. Question without notice. Look, it's still a big problem in Australia. I think my worry is that my concern is we're going to see more cases over time, and I think the National Diseases Registry is going to allow us to track that more, and it's actually going to improve the ability to do the research we need to do. But we know it's here. The key is obviously prevention at source through various health and safety, risk management control measures, but earlier diagnosis was also key. And I think we're in a much better position now to be able to do that for workers and workplaces.
Yeah, perfect. Thank you, Matt. Well, thanks everyone for attending this morning. That will finish us up for today. We'll provide a recording of this webinar to everybody. And thank you once again. Hope to see you next time.